Welcome back to Decoding Respiratory Medicine, your go-to destination for all things related to healthcare, medicine, and life-saving skills. I'm Sidra Fayaz, and in today's video, I'm gonna diving deep into the world of BLS and ALS, which is basic life support and advanced life support, as per American Heart Association guidelines. But before I'm gonna get started, I want to make it very clear this video is especially designed for exam preparation and revision purposes. Whether you are a healthcare professional, brushing up your skills, or a student preparing for your certification exam, you are in the right place. In today's video, I'm going to break down the key concepts, techniques, and guidelines for BLS and ALS, and I will provide you with easy to follow explanations and practical tips to ensure that you are well prepared for any scenario that can come up into your exam. So let's get started. I'm starting with a scenario, as you can see on the screen, that 40 years old male collapsed while running in a park alone, and you saw him and start running towards the scene to help. So how are you going to proceed, what you will check, and what to do next? There are certain steps according to the guidelines which you have to follow. So first is to check a scene's safety. You have to make sure that it is safe for you, first of all, to proceed in to the scenario and help another person. You have to look for the dangerous things around you, like maybe a glass, nail, sharp objects, or an electrical wire. Once you have checked your safety, then what you have to do is to shout out for the person. So what you are going to do, check the response of the patient. How you're going to do that? Tap on his shoulder and say loud and very clear, "Hey, how are you? Are you okay?" Or in a language in which whatever the location you are maybe in. Now, let's see what the guidelines say. So, adult basic life support algorithm for healthcare providers. As I've already told you, that you have to verify a scene safety, check for responsiveness, shout for nearby help, and for example, if you are in hospital, you can activate an emergency response, get AED and emergency equipment, or you can ask someone to do so. Now the second part is to look for no breathing or only gasping, and check the pulse simultaneously, and it could come up with three scenarios. It could be a normal breathing and pulse is felt, no breathing or only gasping, pulse not felt, no normal breathing but pulse is being felt. So what you're going to do in this scenario? So if it is a normal breathing and pulse is felt, it's very simple. Monitor until the emergency responders arrive and patient get better. So no normal breathing but pulse has been felt, you can start rescue breathings depending on the location where you are and the available equipments there. Second is no breathing or only gasping and pulse not felt. In this scenario, which you're going to be encounter most probably in your exam, is to start a CPR as soon as possible. Perform cycles of 30 compressions in 2 breaths. We will discuss the compressions detail later on in the presentation. And as soon as AED is available, you can check a rhythm, whether it is a shockable rhythm or whether it is a non-shockable rhythm. Now, what to check first? It is a CABD now, which is the circulation, airway, breathing, and then defibrillator. Which pulse you have to check? Carotid pulse. For how many seconds? For 10 seconds. And the same thing in this category, 3 scenarios might happen, that no breathing and no pulse, breathing but no pulse, and pulse but not breathing. You have to activate an emergency response system and start a chest compressions. So for example, no breathing and no pulse, you have to start a CPR. Breathing but no pulse, start compressions. Pulse is present, not a breathing, then you have to start with a airway resuscitation. Most important, are the compressions effective? This is very important. Let's dive deep into the compressions. So you have to check that whether compressions are effective or not, because chest compression are the most important element of CPR, and if there is an interruption in chest compression during CPR, no matter how brief it is, it might result into an unacceptable decline in coronary and cerebral perfusion pressure. As we know that the CPR mantra is push hard and push fast, but neither too hard nor too fast, and it should be on the center of the chest. And the critical performance standards for CPR include: maintain the rate of chest compressions at 100 to 120 compressions per minute, and compress the chest at least 5 centimeter or 2 inches, but no more than 6 centimeters or 2.5 inches with each downstroke. Allow the chest to recoil completely, it is very important, between each downstroke, and minimize the frequency and duration of any interruptions in between. Effective compressions position is like an elbow lock and both hands on patient's chest on slightly right border of the sternum, and had to compress, as I am repeating it again, 5 centimeters 2 inches depth, and give time to chest recoil so adequate ventricular filling can happen. Maintain an airway by head up, chin lift. Breathing should be effective when the chest expansion is visible. And total 10 to 12 breaths per minute. Breathing should be adequate, and it should not be more than 12, because it can cause a gastric distension. And if it is not adequate, it can lead to hypoxia. It depends upon the situation. Actually, if you are in hospital, then advanced EOA like ETT can be considered. So one more important thing, if you are a single rescuer or two rescuer, if you are a single rescuer, then start CPR 13 to 2 breaths until AED not arrived, or if you are outside the hospital. If you are in the hospital, then call for help and start the CPR and get an AED check as soon as possible, and check the rhythm whether it is a shockable or not. And if you are two rescuer, then one can start the breathing part and the other with the compressions. Okay, moving on further. So you have started the CPR, give oxygen, attach monitor and defibrillator, check the rhythm whether it is shockable or not. If it is a shockable rhythm, as in VFib and pulseless VT, give a shock and resume the CPR. Then again check the rhythm in 2 minutes. If it's still a shockable rhythm, you can give a shock and then CPR for 2 minutes. Now at this cycle, you have to give epi every 3 to 5 minutes from here onwards, and consider an advanced airway with a capnography. Again check a rhythm whether it is shockable or not. If it is a shockable rhythm, then you have to do a CPR for 2 minutes and then proceed it with amiodarone or lidocaine. And now this is the point you will start thinking about the reversible causes as well. Let's go to the other part of the algorithm, in which it is mentioned that it is not a shockable rhythm like asystole or pulseless electrical activity. In this scenario, you have to give epi as soon as possible and start a CPR. Give 2 minutes of CPR. In the meantime, can maintain IVIO access. Then start giving epi every 3 to 5 minutes and consider advanced airway and capnography. Again, check for the rhythm whether it is shockable or not. If it is not, then CPR for 2 minutes and treat the reversible causes. We will think about the reversible causes and I'm going to discuss in detail later on. So again, after the 2 minutes, you have to check the rhythm whether it is shockable or not. If it's not a shockable rhythm, and if no signs of return of spontaneous circulation ROS, then you have to go again to the 10-11 points in which you have to continue CPR, give epi, consider advanced airway capnography and check the rhythm again. Or if ROS has been achieved, then you have to follow a post-cardiac arrest care and consider appropriateness of a continued resuscitation. This is also a very important part of the algorithm in which they have emphasized on the CPR quality, like push hard at least 2 inches, 5 centimeter and fast, 100 to 120 minutes, and allow a complete chest recoil, minimize interruptions and compressions, avoid excessive ventilation, change compressors every 2 minutes or sooner if it fatigue. If no advanced airway, 13:2 compression ventilation ratio, quantitative waveform capnography. If PAT CO2 is low or decreasing, reassess the CPR quality. Shock energy for defibrillation, biphasic or monophasic. So manufacturers basically it's gonna be the recommendations there, but initially 120 to 200 joules. If unknown, use a maximum available, and second and subsequent doses should be equivalent, and higher doses may be considered. In monophasic, you have to give a 360 joules. Epi dose is 1 milligram every 3 to 5 minutes, and amiodarone is first dose is 300 milligram bolus, and then second is 150 milligram. Then advanced airway, endotracheal intubation or supraglottic advanced airway, waveform capnography or capnometry to confirm and monitor ET tube placement. Once advanced airway in place, give 1 breath every 6 seconds, 10 breaths per minute with the continuous chest compressions. Return of ROSC, which is return of spontaneous circulation. So pulse and blood pressure has been returned. Abrupt increase in PET, PCO2, typically more than 40. Spontaneous arterial pressure waves with intra-arterial monitoring. There is a slide for reversible causes, so I'm going to discuss it later. So this is again just a revision that you have to check a rhythm and check whether it is a shockable or non-shockable rhythm. So if it is a shockable rhythm, which is VFib and pulseless VT, then you have to resume a CPR, give a biphasic initial 120 to 200 joules or monophasic 360 joules, continue CPR after shock, give AP 1 milligrams and amiodarone as described in the cycle. If it is asystole pulseless electrical activity, then CPR chest compressions and AP 1 milligram every 2 to 3 minutes. Epinephrine is 1 milligram 2 to 3 minutes. Amiodarone, as I discussed, first dose is 300 and the next is 150. And lidocaine, first is 1 to 1.5 milligrams per kg and second is half, 0.5 or 0.75 milligrams per kg. And at this point in time, you have to think about the advanced airway support and capnography. So, return of spontaneous circulation. What is it? It is basically pulse and blood pressure that is returned back. We are start thinking about the reversible causes or consideration for therapeutic hypothermia. Let's talk about reversible causes. So, reversible causes of the cardiac arrest are HNTs, very famous HNTs, and these should be on the tip. They are hypoxia, hydrogen ions, acidosis, hypovolemia, hyper or hypokalemia, hypothermia, tension pneumothorax, thrombosis, tamponade, toxins or drugs. So what is post-cardiac arrest algorithm? So once the ROS has been achieved, maintain or manage airway, early placement of endotracheal tube, manage respiratory parameters, can start 10 breaths per minute, sets 92 to 98%, PCO2 35 to 45, manage hypodynamic parameters, systolic blood pressure above 90, mean arterial pressures above 65, obtain 12 lead ECG. This is initial stabilization phase. As explained here as well, that resuscitation. So as explained here, resuscitation is an ongoing during a post-ROSC phase, and many of these activities can occur concurrently. However, if privatization is necessary, you can follow these steps. Airway management, waveform capnography or capnometry to confirm and monitor endotracheal tube placement. Manage respiratory parameters, manage hemodynamic parameters, can administer crystalloids or vasopressors or ionotropics, and your goals of the blood pressure as been mentioned earlier. Now continue management and additional emergent activities. Consider for emergent cardiac intervention if STEMI present, unstable cardiogenic shock, mechanical circulatory support is required, or further on. In a summary, I'm just gonna give a quick summary that have you started the CPR? AED is checking the rhythm. It is a shockable rhythm. In VFib or VT, give a shock. CPR for 2 minutes. Again, check the shock. In this cycle, you have to give epinephrine. Again, check the rhythm, whether it is shockable or not. And then in this cycle, you have to give amiodarone, and continuation of the CPR should be maintained. If it is a non-shockable rhythm, you can start with the epi as soon as possible and then check the rhythm accordingly. Thank you for watching this video, and if you like, please like and subscribe.